This presentation is free of commercial bias, and SNACC does not endorse any particular EVD catheters or EVD drainage systems or transducers. In this video, we will discuss the common indications for external ventricular drain placement. We will discuss how to set up, level, and change the height of the external ventricular drain collecting system. In addition to a preoperative assessment of a patient with an EVD, we'll also talk about transportation in a safe manner of patients, as well as the intraoperative management and EVD waveform interpretation. There are several common indications for the placement of an EVD. They include the acute symptomatic hydrocephalus resulting from aneurysmal or traumatic subarachnoid hemorrhage, intracerebral or intraventricular hemorrhage with decreased level of consciousness, acute ischemic stroke that may cause mass effect and or obstructive hydrocephalus. EVDs can also be used for ICP monitoring and traumatic brain injury or controlling of intracranial hypertension. The indications for EVD placement and TBI are listed below. EVDs can also be utilized for malfunctioning or infected ventricular peritoneal shunts and other neurological emergencies. It can also facilitate intraoperative brain relaxation and targeted therapeutic interventions such as TPA and antibiotics via the catheter. Here are three axial CT scans representing disease processes that commonly require EVD placement. On the far left, aneurysmal subarachnoid hemorrhage resulting in hydrocephalus. In the middle tile, intracerebral hemorrhage with intraventricular extension. And on the far right, acute ischemic stroke in the cerebellar region that oftentimes leads to obstruction of the fourth ventricle and obstructive hydrocephalus.
Complications associated with EVD placement are unfortunately common. The rate of hemorrhages in the literature ranges from 0 to 41%. However, fortunately, the rate of symptomatic hemorrhage is much lower, around 3%. Aberrant EVD location can lead to neuronal injury as well as hematomas associated with the tract and or rupture of intracranial vessel. Infection ranges from 0 to 28%. However, with the advent of antibiotic impregnated catheters, this rate is much lower, around 1 to 3%. EVD catheters can become occluded or malfunction, can also overdrain cerebrospinal fluid. This can lead to subdural or epidural hematomas, rebleeding of ruptured hematomas, or paradoxical herniation or outward herniation. Here are two axial CT scans showing on the left tile a tractoma or hemorrhage associated with the tract of the EVD. The tile on the right unfortunately shows not only a tractoma but also a large intraparenchymal hemorrhage associated with placement of the EVD. There are a multitude of EVD catheters that are commercially available, and they range in sizes from 2.4 millimeters in outer diameter to 3.5 millimeters in outer diameter. The larger catheters are typically used for patients with intraventricular hemorrhage. There are also catheters that are impregnated with antibiotics and others that are coated with additives that prevent platelet adhesion and thrombin formation. As with the EVD catheters themselves, there are a number of different collecting systems. It's important to familiarize yourself with your institution's type, as there are several that have components that are disposable and non-disposable, and you'll need to ensure that you inquire both the consumable portion and non-consumable portion of the collecting system. Some collecting systems have gradations for millimeters of mercury and centimeters of water, whereas others can limit the amount of hourly CSF withdrawal. So it's important to familiarize yourself, as there are many differences in these collecting systems. Looking at the collecting system of an external ventricular drain for the first time can be somewhat overwhelming, but as soon as you familiarize yourself with the purpose of each of these stopcocks, you'll see that the device is quite simple in its design. The stopcock labeled number 1 is a part of the flushless transducer labeled number 2. This stopcock is used only in the setup and flushing of the transducer. Stopcock number 3 is utilized only in the zeroing of the transducer. Stopcock number 4 is the most important and will be utilized throughout the care of the patient. This stopcock, when in the 12 o'clock position, does not allow for cerebrospinal fluid to go into the beer trough and allows for the accurate measurement of intracranial pressure. When this stopcock number 4, is in the 3 o'clock position, it's what's known as open to drain, and the intracranial pressure noted on the monitor will be much lower than the actual intracranial pressure of the patients. Labeled number 6 is the collecting system, which has gradations for milliliters. This is very important to notice in the operating room, as if the amount of CSF per hour changes, either increases or decreases, this is a conversation that needs to be had both with the neurosurgery attending and the anesthesia attending. Stopcock number 7 is only used at an hourly time frame to remove the CSF from the collecting system. Now that you're familiar with the EVD collecting system, let's learn how to appropriately set it up. In addition to the collecting system that will become sterile from the manufacturer, it's important to gather supplies before attempting to set. You'll need the flushless type transducer. In addition, you'll also need syringes filled with preservative-free saline. The outside of the syringe will need to be sterile, as well as the contents. You will need sterile gloves, as well as sterile caps that will go over the stopcocks. It's incredibly important to maintain sterile technique throughout the setup of the external ventricular drain collecting system. Ventriculitis is something that is tolerated very poorly, with mortality in the literature can exceed 40%. Once your hands have been washed and you've placed sterile gloves on, grab the flushless type transducer and place it onto the stopcock labeled stopcock number 4 in the previous tile and tighten. Next, grab one of the preservative-free saline flushes from the sterile packaging and attach it to stopcock number 1 in the previous tile. Once this is tightened, open the stopcock and flush the distal tubing and collecting system with sterile preservative-free saline. Once this is done, turn the stopcock labeled number 4 in the previous tile to the 12 o'clock position. This will allow for flushing the tubing that's directly connected to the EVD. Then grab all your sterile caps from their sterile packaging and cap all of the open ports on the stopcocks within the collecting system. Now I'll turn our attention to the leveling of the collecting system. You'll see here that there are several types of levels, the most common being the carpenter's level, which is essentially a bubble type level attached to a string. The second type is a laser level, which has a bubble level within it and emits a laser beam that can be leveled to the patient's external auditory meatus. Again, it's important to familiarize yourself with your institution's type of leveling system. Leveling of the collecting system refers to the position of the transducer in respect to the patient's external auditory meatus. You'll see with most collecting systems that there are 2 ways to affix the system to the IV pole. Most will have a compression type and a string type of adherence to the pole itself. Once the collecting system is loosened on the IV pole, grab the string in carpenter's level and place it towards the patient's external auditory meatus. Move the collecting system up and down until the carpenter's bubble is level. Once this is done, you'll need to re-adhere the collecting system to the IV pole to ensure that it does not move up or down. Here's another perspective showing the collecting system 0 point, which is collinear with the flush type transducer, all in line and level to the patient's external auditory meatus. Once the collecting system has been leveled to the patient's external auditory meatus and the collecting system has been adhered to the IV pole, you're able to set the drain height. You'll see here that the collecting system is brought down to the 0 position and then incrementally moved up to 0, 5, 10, 15, or 20 centimeters of water. To ensure that intracranial pressure derived from the system is accurate, you must first zero the EVD. To do so is not unlike zeroing an arterial wave or CVP transducer in that the stopcock must be open to air and zeroed at the monitor. The stopcock utilized for this process is directly proximal to the transducer itself. Open this stopcock up and remove whatever cap you may have on this. This will open the transducer to air. Now you're ready to set the 0 on your monitor. Once this is done, return the stopcock to the upright position or 12 o'clock position and place a sterile cap onto the stopcock. Here's a short video of the zeroing process. Remove the cap and turn the stopcock to the 3 o'clock position. Set the 0 on the monitor as the transducer is open to air. Once the 0 has been accepted, take the stopcock back to the 12 o'clock position and replace the cap. EVD collecting system should never have a pressure bag attached. If you come across a collecting system with a pressure bag, immediately disconnect, inform the primary team, and obtain imaging, because this may lead to increase in intracranial pressure and/or herniation and death to the patient. In addition, SNACC recommends against the utilization of flush-type transducers. This is an effort to prevent the inadvertent attachment of a pressure bag to these systems. We will now move to the safe transportation of a patient with an external ventricular drain. Patients with EVDs are often moved off of the ICU for imaging, angiography, and the operating room. So it's important to know how to safely transport these patients, as it often comes up. Let's quickly review the 2 positions of the stopcock. On the 3 o'clock position, the collecting system is open to drainage of the patient. In the closed position, or the 12 o'clock position, the stopcock is closed to the collecting system. However, it allows for transduction of accurate intracranial pressures. We recommend against closing the drain at the connection between the EVD and the collecting system, as you are able to transduce ICPs in this manner. Let's look first at the unsafe and improper way to transport a patient with an EVD. The collecting system in this video is removed from the IV pole and placed onto the bed. This can be below the level of the external auditory meatus, leading to siphoning or over drainage of CSF, which can lead to subdural hematomas, herniation, and/or death of the patient. In this video, you'll notice the first thing that's done is the EVD is moved from the open position to the closed position prior to movement of the collecting system relative to the patient. The collecting system is taken off of the IV pole and placed onto the patient's bed, clamped temporarily, and then leveled at the patient's external auditory meatus. The entire time that the collecting system is moved, it is closed to the patient, therefore not allowing the unsafe drainage or over drainage of the patient. Let's now turn our attention to the intraoperative management of patients with external ventricular drains. It has been noted several times in this video that the stopcock position that's in line with the EVD and the collecting system plays an essential role in the care of patients with EVDs. The stopcock in the 12 o'clock position denotes accurate measurements of intracranial pressure, whereas the stopcock in the 3 o'clock position, or open to drain position, will not give you accurate intracranial pressures, but will allow for the removal of cerebrospinal fluid from the patient. With the collecting system in the closed position, we can look at the components of the intracranial pressure waveform.
The first portion of the waveform is known as the percussive wave, and this denotes pressure reflections off of the choroid plexus. P2 is important to note whether or not the patient has normal or abnormal intracranial compliance. If intracranial compliance is normal, P2 is normally only 80% the height of P1. P3, or the third portion of the ICP waveform, is known as the dichroic wave, and it represents the aortic valve closing. In this example, you'll notice a difference in the ICP waveform whereby P2, or the second portion of the intracranial pressure wave, is taller than P1. This denotes abnormal intracranial compliance seen in this patient. Here's another example of a patient with poor intracranial compliance where the P2 is quite exaggerated over P1. And yet another example where P2 is actually higher than P1. Both patients have abnormal intracranial compliance. It is very important to note the color and consistency of spinal fluid within the collecting system prior to transporting a patient off of the ICU. Normally, cerebrospinal fluid is straw-colored and transparent, but oftentimes the fluid in the collecting system is bloody, tea-colored, or xanthochromic given the indications for EVD placement. The reason it's incredibly important to note this prior to taking the patient to angiography or the operating room is that acute changes in cerebrospinal fluid volume, output, and color can denote several things, such as re-rupture of an aneurysm intraoperatively, or extension or rebleeding from an interventricular or intraparenchymal hemorrhages. If you note any of these changes, it's incredibly important to let not only the anesthesia staff attending know, but also the neurosurgery team, as there may be an intervention that needs to take place in an expeditious fashion. While in the operating room, it's important to remain vigilant. You should document intracranial pressure as well as cerebral perfusion pressure. Document and note the amount of cerebrospinal fluid drainage. It's also important to note if any cessation of drainage. This may be indicative of drain clogging or malposition. It's important to note the color and consistency of drainage. Xanthochromic or clear drainage that turns into hemorrhagic drainage may be indicative of an intraoperative rupture of an aneurysm. You should also note the drain height relative to the reference level, and note all positions of the stopcock, whether they be open or closed to the patient. This concludes the Society of Neuroscience and Anesthesiology and Critical Care's video of the perioperative management of patients with external ventricular drains.